So, welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have the pleasure to bring back one of my favorite speakers and favorite person in the world, Dr. Dhruv Singhal. So, he is an associate professor of surgery at Harvard Medical School and served as the co-director of the Boston Lymphatic Center and director of the Beth Israel Decanos Medical Center Lymphatic Center. He completed all his formal surgical training in Boston. He's a board certified in general surgery as well plastic and reconstructive surgery. He then pursued a fellowship in adult craniofacial surgery in Changchun Memorial Hospital in Taiwan and microsurgery at the China Medical University Hospital as well in Taiwan. His clinical focus is in cancer reconstruction, and Dr. Singhal is a pioneer in immediate lymphatic reconstruction for the prevention of lymphedema in high-risk patients and performs liposuction, lymphovenous bypass, lymph node transplantation for the treatment of chronic lymphedema. He also performs the entire gambit of breast reconstruction from oncoplastic procedures to perforator flaps operations. Dr. Singhal's research focused in lymphatic reconstruction. In 2021, he was awarded an R01 from the NHI to further delineate the functional lymphatic anatomy of the upper extremity. And in 2022, he got award for another grant to lead a team to map the human lymphatic system for the Human Biomolecular Atlas program at the NHI. He was on my episode 6 almost 2 years ago, where he shared the path that brought him into his specialty as a lymphedema surgeon, as well as some of his personal journey. This time, he's going to go deeper into different options for lymphedema surgery and exciting information about his research in the lymphatic anatomy. So thank you again for being with me, Dr. Singhal.
Charlie, thanks for having me. It's always really special in a way to come back home, right? When I started my lymphatic practice, it was with you, it was with a team at UF, and you will always have a special place in my heart. So thank you again
Yeah.
for having me.
So as well, we're still missing you every day, you always have a place here whenever you want to come back. We have not been
Likewise.
able to fill your shoes even after what? How many years now? 8 or something? I don't even
Well,
know.
maybe I'll come back in the dead of winter here in Boston when I'm freezing, okay?
Yeah, that's fine. That's totally fine. So could you walk us through the main type of surgeries that you use in treatment to treat lymphedema? Lymph venous bypass, vascular lymph node transfers.
Yeah, so the way I think about it, Charlie, is when a patient presents with lymphedema, I look at it as two families of operations. One family of operations are called physiologic operations, and that's where we're actually trying to regenerate or reroute the lymphatic system. And the other one is what we call our debulking surgeries, and that's where we go in and we remove tissue. And what's critical there, and what most people don't know, I would even argue most physicians don't know, is that in lymphedema, in most cases, I would say 80% of lymphedema cases, regardless of whether they come in with primary or secondary lymphedema, they have fat hyperplasia. So they actually have new fat cells being created, and it's developing in the limb, if we're talking about peripheral lymphedema, where they have a lymphedema. So in the debulking surgeries, we go in and we remove it. So those are the two basic families: physiologic operations, where we're rerouting the lymphatic system, that's like lymphovenous bypass, lymph node transplant, and then debulking, where we're actually going in to remove tissue that has been abnormally collected over time.
And how do you determine which procedure is right for a particular patient?
Yeah, that's a really important question, and it's really determined through a workup where we are assessing how much fat has the patient developed, and we can tell this. We can actually tell this through clinical exam. Can start giving us part of the picture. Even looking at things like bioimpedance as it relates to volume can start telling us this, and then for us, MRI is actually really critical. Certain sequences in MRI can really tell us not only whether or not the patient has fat hyperplasia, but where it is. Is it in the calf? Is it in the thighs? And is it across the entire extremity? And so that's ultimately the first breakpoint in our algorithm is if they have the fat, then in my hands, I am going to debulk the patient first, get control of the limb before we go back for regenerative procedures, which are usually 1 or 2 years later.
Okay. And what kind of results do patients typically see post-surgery?
Yeah, and I think this is again, all your questions are hitting at the heart of all of this. So, what's really important to understand, and I know you know this, but for the community to know. So there's no cure for lymphedema in 2025. There are so many of us working towards it, but I don't think there's a single surgeon or a medical doctor that'll walk around and say they can reproducibly cure lymphedema. Do all of us who do this have the cases that we've hit a home run on? 100%. But nobody can really figure out why that patient did as well as they did. So it's really important in the beginning, and this is how I start all my consultations. It's actually my first focus, is understanding what is the patient looking for, because there isn't a reproducible cure today. And so what we do is we actually take the disease, we break it down into goals, and we have like 6 basic goals that we've identified most lymphedema patients are looking for. And if we gave them all 6 goals, then that's a cure. And that's always my drive and aim, but I can't have that be the patient's expectation. I make them take those 6 goals and tell me which ones are their highest priority. And then we really start our conversation there. So you were asking, so what are the outcomes, right? So it's important to understand upper extremity. Again, if we're sticking to peripheral lymphedema, arms and legs, upper extremities tend to do better than lower extremities. Each surgical family I talked about, debulking or physiologic, has huge benefits, and then there are some drawbacks. For example, for debulking surgery, patients should expect dramatic improvement in their volume. This is the procedure where you get the wow effect. Patient will wake up, look down at their limb, and usually say, wow, I never knew my limb was going to be that size again. They're going to have a reduced risk of infections, right? Almost by 83% is what the data shows in the long term.
You say 83%.
83%.
Oh, wow. Okay.
They're also going to have an improvement in symptoms. With symptoms, I'm talking about heaviness, achiness, tightness, classic symptoms patients come in with. What are they not going to get? What they're not going to get is a reduction in compression. And depending on how much compression they had when they walked into the office, they might need to go up. In order to maintain the results of a debulking procedures, patients have to wear compression 24/7. And so there is the kind of a give and take on debulking surgeries. Now let's go over and let's look at physiologic surgeries. Physiologic surgeries, patients similarly reduce risk of infection, continue to improve symptoms. But critically, these are the surgeries I do really to drive down either the class or the amount of time of compression a patient needs. Okay. Now, the drawback of these surgeries is you will not get the wow effect. And why am I saying that? I'm saying that because, at least at our center, and as we did at the University of Florida when I was there, we never took a patient to the OR until they were maximized, meaning their conservative therapy was maximized.
Mm-hmm.
So there's only 2 things that make up volume. It's either fluid or it's fat.
Mm-hmm.
So if a patient's maximized, it's not fluid anymore, because a great CLT such as yourself can do wonders. They can make a leg look completely different with appropriate treatment. So all that's left is what you can't squeeze, which is fat, right? So if you do a physiologic procedure with somebody who has fat, and that's at the discretion of the surgeon and the patient through, joint decision making, that patient should not expect to wake up and see a dramatic change in their volume. So those are kind of the expectations for each family of operations that we offer in lymphatic surgery.
So if we have, and I know that's exactly what happened when you were here with us. So we did all the lymph node transplants, and we have great results on some of the volume, and then we got some great results on symptoms. But how at that point we were like, what do we do with this fat, right? So now you know what to do with this fat, which was a
Yeah,
liposuction, correct?
correct. And I just want to pause there because Sterling, I bring this up all the time with my patients. And if any of my patients are listening, they'll know this. I talk about the evolution of my practice. That
Mhm.
when I was at the University of Florida, I did what I was trained to do in Taiwan by my great mentor, Professor Ang Chi Chen. I was taught to do transplant, which is really a regenerative procedure. But as you know, these patients will come back and they say, I feel great, but why is my arm still big?
Yeah.
And you're smiling because you and I kind of stared at each other like, yeah, what are we missing here? And we were missing the fat. So then I backed up and I said, wait a second, let's go after the fat first.
Yeah.
Then we go back and we regenerate. We do the regenerative procedure.
But I know.
Sorry, you asked me a question and I might have not
Yeah.
answered it.
No, so that's kind of we look into liposuction, meaning like you go after the fat with the liposuction, right?
Yeah, that's exactly right. So the liposuction we do, and I want to be clear, this is not
Mhm.
cosmetic lipo, and I want to be
Yes.
clear because
Yeah.
the community needs to understand this, and frankly, insurance companies need to understand this. This is one of the most aggressive forms of liposuction that you can do. It's labor intensive. It is timely. It takes time. We do it under tourniquet control. So Håkan Borson has really taught the world the modern approach to debulking. You do this under tourniquet control. You use a power-assisted lipo. There are people who use different techniques, but in my hands, I have found this technique to be completely reproducible with very good outcomes from our patients. And you literally take all the fat from the skin down to the muscle fascia. And
Wow.
because you're under tourniquet control, you have to do this using a very aggressive machine that's almost like a mini jackhammer. And
Wow.
I'll tell you, when I did 2 of these cases in one day, I walk away, my hand is shaking. I mean,
Wow.
this is there's
Intense.
some occupational hazard here to
Yeah.
do this, but this is what it takes to get rid of this tissue because it's not normal fat. Depending on the scenario, the gender of the patient, it can be concrete, for
Yeah.
example, when we get in there. So this is the debulking approach we do, and we put the patient right into compression, right at the end of the case, um, to maintain everything.
Got you. So you're still doing depending on the patient, right? So if it's more fluid based on the MRI, you go first for the vascular, and if it's more fat, you go first for the fat, correct?
That is correct.
Okay.
But I will tell you, our data is showing the majority of patients are developing fat. So it's really interesting. So a couple of things here. I mean, you and I could talk forever about this. Um, if, why is there fat being developed there, right? It's a question I don't know if I know the exact answer to. I don't know if anybody has the exact answer to. Håkan Borson has shown that in lymphedema and the inflammatory process, baby fat cells turn into mature fat cells. Another thing to think about is the lymphatic system transports fat. It's one of the jobs of the lymphatic system. And so if you can't get the fat out, then the fat will collect. Our team actually, led by Dr. Greg Westcott in endocrine and Dr. Evan Rosen over in endocrine, just published a landmark article or put out a landmark article showing using single nucleus RNA sequencing of fat in lymphedema patients.
Oh, wow.
We took fat from the side that had lymphedema, and we took fat from the healthy side. I'm very thankful to our patients who allowed us to make an incision on their normal side to get this fat. We found that the fat is not the same. One of the first things we actually found is that this is true hyperplasia, not hypertrophy. Hypertrophy means you have a number of cells and the cells are getting bigger.
Mhm.
Hyperplasia means there are more cells being formed. And so we were able to show that for the first time. And Dr. Westcott and Dr. Rosen have actually identified some pathways that are being upregulated in these fat cells. And obviously, the future goal would be could we potentially come up with some kind of drug that could block these pathways? So if we have a patient who we're concerned about, we can give them a drug and prevent them from ever getting fat. But that is work that's ongoing.
Got you. So I know you're all about research, and I know you're doing a lot of really great things about the lymphatics anatomy. So you want to tell us what's happening with that? And I'm dying to hear this, and I've been dying to hear this for months now. So
Thanks, Billy. So this might be one of those things where you have to cut me off because I can talk forever about this. So, I think I'm very blessed in my professional life. I'm blessed throughout my life, but I'm also blessed professionally. And one of the things I'm blessed about is I found a question that I think is so important. It will unlock, I think it will unlock future approaches that will replicate a cure for patients with lymphatic diseases. Specifically, let's just talk about peripheral arm and leg lymphedema, and especially in the secondary scenario, meaning somebody's born with a normal lymphatic system, and then they have an insult, and then they develop lymphedema.
like our breast cancer patients, right? The majority, like all of them,
Exactly.
develop
Let's go with that. Let's stick with the breast cancer patient. The question that's fascinated me for now close to a decade is we know the number one risk factors for getting lymphedema is an axillary node dissection and radiation, right? Regional lymph node radiation. Well, it turns out if you take 3 women and you provide the exact same treatment to them for breast cancer, only one of them gets lymphedema. 2 of them don't. And we have no idea why. There are certain risk factors that we've identified. I just named 2 of them, right? The third risk factor, which is a personalized risk factor, is BMI, somebody's height, weight, the percent fat content. Well, as that goes up, the risk of lymphedema goes up. That we know. We actually still don't understand why a certain individual goes on to develop it or not. And one of the theories that of course, I'm biased, but I'm convinced of, is that it's going to be lymphatic anatomy. Variations in lymphatic anatomy exist between healthy individuals. And these variations, I believe, are one day going to lead to like a risk calculator where a patient will come in with a newly diagnosed breast cancer. We'll say, okay, you need to have your lymph nodes removed for X, Y, or Z reasons. We're going to undergo certain imaging, and this imaging is going to map out your lymphatic anatomy. And based on that, I'm going to tell you what your risk of lymphedema is. And based on your risk of lymphedema, we're going to do, X, Y, Z interventions to mitigate that risk. And so it's going to become what, we many of us talk about in medicine today, which is precision medicine, individualized medicine, where we figure out what is a individual's specific risk. I'll tell you, we were very lucky last year. I'm on faculty here at Beth Israel Deaconess Medical Center, and I have an appointment at Harvard Medical School. So I was able to apply for a think tank through Harvard University. Harvard is called the Harvard Radcliffe Institute, and we were approved to do this. It was very competitive, and we were able to do a 2-day think tank. We were able to bring in world experts in lymphatic anatomy and imaging. We were put into a room, and we had to talk for 2 days and kind of establish certain things that we know, we don't know, and certain things that we feel are really important for us to go after in the future. And it was amazing. Like I don't think anybody truly understands the lymphatic system completely, but it's amazing to be in a room full of people
Oh my
who have
God.
dedicated their lives to
That's so
this,
awesome.
and then see what we agreed on, what we disagreed on. And one of the really important things that I took out of this think tank is when you look at lymphatic anatomy. Let's just take the arm. It's very equivalent for the lower extremity, but let's take the arm. And you think about the superficial lymphatic system, which is the lymphatic system above the muscle fascia.
Mhm,
And then you look at the lymphatic system below the muscle fascia,
mhm.
between the fascia and the bone. The dominant lymphatic system is the superficial system. End of story. It's the dominant lymphatic system because there are like 30 lymphatic channels there. But if you go into the deep system, the lymphatic channels are only riding with the great vessels. So there aren't that many. Turns out these vessels are of similar size. Hiro Swami really emphasized this to me. He's a plastic surgeon, he's a lymphatic anatomist now, out of Australia, world renowned. And so it's clear just from a capacity perspective, the superficial system is the dominant system.
Mhm.
Now, when you do a lymph node dissection, that superficial system takes a huge hit.
Yep.
And I'm so fortunate. I work with incredible young minds, and I have great lymphatic research fellows with me. James Fanning was my research fellow last year. He's a med student at UVM. Is going to do great things. And I remember one night he came into my office and he said, "Drew, I think this is all coming together for me." And I said, "James, tell me what you're thinking." He says, "Listen, what I think happens is when the superficial system begins to fail,
Mhm.
it tries to find backup superficial pathways.
Hmm.
So these are other pathways living in the superficial system that have avoided the armpit. We actually know there's a pathway called the Miscagni-Sappi pathway in our literature. We like to call it the lateral upper arm pathway. It sits right here in this deltopectoral groove. It avoids the armpit, and there's a critical lymphatic channel there. In fact, there are a lot of cases reported by a French anatomist that showed us that patients can have an axillary node dissection, never develop lymphedema, and then they get a skin cancer right over this site. The dermatologist goes in, just removes literally like a small area
Oh
of skin,
wow.
and patient develops full-blown lymphedema 2 days later. So that is proof to me, anecdotal proof that this is what the issue is. There's another critical pathway that exists in the back of the arm. It's your tricipital pathway, sometimes called Kaplan's pathway, after Professor Kaplan and from Argentina, who described this. And that pathway goes to the back and then enters the armpit posteriorly. Turns out our research is showing us that most breast surgeons leave those lymph nodes that are likely draining that pathway behind, even with a full axillary node dissection.
Hmm.
So those are two superficial pathways that we think that when the superficial system takes a hit, like after an axillary node dissection radiation, it's trying to reroute to. Turns out each of those two pathways have good variants and they have not so good variants.
Hmm.
And so maybe there's some combination there that explains an individual's risk for getting lymphedema. And then there's a third pathway. They said the deep pathway is not the main pathway, but it's clear to us that when the superficial pathway is failing or it's challenged, the superficial pathway will try to find a way to the deep pathway. And there are certain areas we know where it will really try to do this. One area is the wrist,
Mhm.
another area is the elbow. One of the biggest challenges of studying these pathways is modern technology, believe it or not, does not allow us to image the deep lymphatic system. We
Mm.
can image the superficial system. So we understand better. I'm not going to say completely, but we understand better the superficial backup systems. But the superficial deep backup systems require us to merge different imaging modalities and make some educated guesses. Let me stop there because
Yeah, that's
I want to give you a chance to.
so line words. So what I'm understanding is during the type of the breast surgeon will do an axillary dissection. If they avoid those pathways, that should decrease the risk of lymphedema. Is that correct?
Yes and no. Those pathways are never in danger.
Okay.
They are outside the armpit.
Yeah. Okay. Got you. Okay.
But those pathways, let's just say, are variably formed in an individual.
Okay.
Certain women have those pathways beautifully developed,
Okay.
others not so much. So if those pathways are not there, and if they're not, or they're not really well developed,
Higher
then
risk.
how much can they compensate
I got
when
you.
the main system gets wiped out?
Got you. Can you do anything from the surgical standpoint to those pathways? Like, you know how you do the lympha?
Yeah.
Can you do something from the surgical standpoint to improve their lymphatic system on those pathways to decrease the risk of lymphedema?
Yeah, and I think this is the key, Charlie. It's what do we do with this knowledge? Like I said, we want to map women and figure out what their individual risk is. So let's say theoretically 5 years from now, we figured it out, and I'm sitting in my clinic in front of a woman who does not have lymphedema, but I know she has a 100% risk of getting lymphedema. What am I going to do? So absolutely, there's a lot of ways to think about this. One way to think about this is what you just said. Let's take these backup pathways, let's augment them. Let's make them even better,
Mm-hmm.
right? And there are ways that we could talk about doing that. When I say the pathway is not as good in these variants, it turns out that in a good variant of this pathway, it runs the entire length of the arm.
Oh,
So if
wow.
the main pathway goes out, the entire arm can drain to the backup pathway. But in the not so good variant, that pathway only exists in the upper arm and it's missing in the forearm. So
Okay.
to go right to your point, maybe we need to find a way to connect them,
Okay.
forearm to that backup pathway. So that would be an option. Another option is, well, now that we know the patient has a 100% risk of getting lymphedema if we do nothing, could we do a lymph node transplant in real time?
No.
When the breast surgeon removes the diseased lymph nodes, could we replace lymph nodes in the real time?
So
We're
we
going
did
to do
it.
this. Yeah.
We did it.
What's that?
We did it here, right? Didn't we? You? No, 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 no. You did
No,
it.
we would do it afterwards,
Yes, you did it with
after the patient
CIP. Yeah.
developed lymphedema,
Yes, yes. You did it with
right?
CIP. Yeah. Yeah.
Right. So that was a delayed reconstruction. Patient already had lymphedema.
That's right. That's right.
But in the future, is there a future here where we do it up front so the patient never needs to know what the word lymphedema is?
That would be great.
And then a third option, and there's many options, but just to answer your question, give you some of how I'm thinking about it, how we think about it, is if you know your risk is 100% of getting lymphedema, maybe your cancer team will approach that axilla differently.
Okay.
Maybe they'll be like, okay, now everything in medicine becomes a risk benefit analysis, right? So I think this is, I genuinely believe this is going to drive a lot of our decision making in the future. And for those who live with lymphedema, I don't want you to think this research won't help you. I actually believe this research is going to help us identify which parts of the arm are
Mhm.
most vulnerable
Yep.
or what's leading to lymphedema, and we're better going to be able to guide surgical treatments for those who have lymphedema. So I think there's a lot to unpack here, and that's what we're working on.
That's so exciting. I cannot wait to hear more about it and what are you moving into these results. That's very exciting.
Thanks.
So What does the recovery process look like after lymphedema surgery?
Yeah, so it's a great question. It really depends on what kind of surgery you have. It can go from everything from you go home the same day and you have a very, very small incision on you to you had a laparoscopic approach to the belly, which means, or even an open abdominal operation, and you can't walk for 3 weeks. So let me walk you through um, the surgeries and mainly the recovery processes. So for debulking surgery, okay, these surgeries, patients should expect, they're usually in the hospital 2 days. They should expect not to feel like themselves again for about 4 weeks for an upper extremity. I say about 6 weeks for a lower extremity. I will say that they will be changing their garments every 2 days early on, and then every day after about 2 weeks. And these patients usually require new garments because of the volume changes that occur pretty early on, like right around the 3 month mark, maybe sometimes approaching 6 months. But early on, we got to be getting new garments on to make sure they're fitted for the patient. This procedure does have a reputation of being very painful. Our team has worked really hard with our anesthesiologist to address this intraoperatively in the operating room. And we've had some really nice results postoperatively. So we think as long as attention is paid to the pain early on, patients do very well, both in the short and long term. In terms of physiologic procedures where we're trying to reroute the lymphatic system, I think that for lymphovenous bypass, these are very short operations. I mean, these are very small incisions. These are about 2-3 centimeters. We only go about, inch deep, 2-3 centimeters deep. We close these incisions. Patients go home the same day. We usually wrap them in the post-op area. They go home the same day. They take off the wrap the next day, and they go into their normal compression. They tend to just get back to their routine pretty quickly, if not immediately, and go from there. Lymph node transplants are much more involved. When I was in Florida, we would take the transplants from the groin, we would take it from the base of the neck. I think the last transplant I did in Florida before I left was an omental transfer where we took it from the abdomen. We now almost exclusively take it from the abdomen. And the reason for that is there's no risk of causing lymphedema when we take it from the abdomen. But that entails going into the abdomen. And that's not a small undertaking in terms of patient recovery. Even when we're able to do it laparoscopically, and I do this today with my co-surgeon, who's a minimally invasive specialist, Dr. Jordan Bonin, from general surgery, these patients are going to feel it for about 6 weeks in the abdominal area. Even with a laparoscopic surgery, there's a lot of torquing of the muscles and whatnot to get these lymph nodes. So that's actually the number one complaint we get from patients after lymph node transplants. They actually don't even feel it in a way where we put it in the arm or the leg. They're like, Doc, why does my belly hurt? And that's why. So that takes about 6 weeks to recover from. Now, for an upper extremity, we put them into a splint, mainly to keep the lymph node transplant stable for about 1 to 2 weeks. In the lower extremity, we do it for 3 weeks. And that's important because they're not allowed to walk for 3 weeks. After 3 weeks, we do let them walk fully. So clearly, the lymph node transplant is a larger recovery than the bypass. And the debulking surgery is kind of in between those two in terms of recovery.
Okay, how about your MLD? At one point, do you do any manual lymphatic drainage at any point with the lymph node transplant?
Yeah, so it's, we really leave this. I leave this to my therapist to make the decision. As you know, I am not a therapist, okay? You are the world expert in therapy. I am the expert on surgery. So I really rely on my therapist to make those decisions, just like I did in Florida when we worked together. to make those decisions on MLD. Is it beneficial? Is it not? Generally speaking, I would not want any massage on the incisions for about 4 weeks, 4 to 6 weeks after surgery.
Okay.
So that's just as a general rule. But as you recall, when we were working together in Florida with transplants, especially when we put them down in the forearm, sometimes we would do MLT going down to the transplant.
Yeah.
So, but generally, I wouldn't want anything on incisions for about 4 to 6 weeks.
Okay, great. Are there any common misconceptions patients have about lymphedema and its surgical treatment?
For me, I think there are two things. One, patients sometimes come in and expect a cure. And that's where I spend a lot of time in my counseling because it's not easy to tell somebody there's not a cure for something they live with today. But they need to know that before they embark on any of this because they have to be very clear about what they're trying to achieve. Because the clearer we can be on that, the better the patient's going to do, both physically and emotionally, with whatever we undertake together. And I think the other misconception I get, and I want to be fair to patients living with lymphedema on that first misconception. I would say the majority of patients get it by the time they get to our clinic. They've been through a lot, unfortunately. But that's an important misconception that some patients come in with, and we're on watch for, because I think it's very important to address. A misconception I saw a lot of, and maybe I'm seeing a little less of now, is patients coming in, walking in the door and saying, I want a lymph node transplant, or I want a lymphovenous bypass. And they're saying that because they're seeing that in the lay literature, and they're associating that with the best outcome. And that's not necessarily the truth. And so I would just say, really rely on your lymphatic surgeon, to look at your case individually and guide you on what they think is best. And, part of it can be how a lymphatic surgeon's trained and what their tool set is. But that's important for a patient to consider when they're sitting with a lymphatic surgeon, right? And formulating a plan together.
Got you. So I know sometimes patients think, and we have some patients who actually didn't have to wear compression garment after you did some lymph node transplant. That was great, and they did really well. But what role do the compression garments, manual lymph drain, and lifestyle change play after surgery, right? Like, yeah, you did all your part, the patient did that, and then what is the expectation of life after that?
So that's a beautiful question. So, okay, so you're talking about after lymph node transplant,
Yeah.
right? Okay, so this is great because what I tell my patients is I have hard data and I have soft data, okay? With debulking surgeries, my data is hard. Like I can tell you, you're going to have X% reduction. You're going to absolutely have an improvement in quality of life. Your infection rate's going to go down. The data is crystal clear on that. When we get to physiologic procedures, LV bypass, lymph node transplant, in my hands, I do those two procedures with one major goal: reduce the amount of compression a patient needs. And what you're asking me, Turley, right now is, okay, so what should they expect? So, in our patients who we have about 5-year follow-up now, okay, we expect 14 to 20% of them to be able to come off compression completely. We actually are now seeing this in our lymph node transplants multiple years out. The more important question then is, because if a patient's sitting in front of me, they're like, okay, so I have a 1 in 5 or a 1 in 6 chance of being off compression. What happens if I'm in the other group?
Uh-huh.
And what our data is showing us is because most of these patients have been debulked, right? So they're at 168 hours of compression before the transplant. That is 24/7 compression, 7 days, right? 7 days a week, 24 hours. Um, what we're able to do is drop them to an average of 70 hours a week. So we're going over half of the
What they use.
time. They
Oh,
do
very
not need to work compression and still maintain a normal volume that we achieve with a debulk.
That's very good. That's very good. Um, what are some of the biggest challenges in treating lymphedema today?
That's a good question. Um, I think two things that come to mind out of the gates. When I think about lymphatic disease, I think there are two keystone problems, and they're kind of sister problems. They're somewhat related to each other. It's our ability to measure the disease and our ability to see the disease. I think those are the biggest issues. What do I mean by that? Well, I talked earlier about lymphatic anatomy, right? We can only see the superficial system. We can't see the deep system. And then we can't see the connections between the superficial and deep systems. And I think that is a huge problem. Huge problem. And credit to the US government and the Advanced Research Projects Agency, who made a call out called LIGHT to actually, they're pouring, I don't know the exact number, but there's a lot of money being poured into this problem and trying to figure out how can we improve our imaging so that we can actually see the lymphatic system more completely. The other issue is measuring the disease. And again, the LIGHT program addresses this as well. And there's another program, GLIDE. These are all through ARPA-H that are working on this, led by Kimberly Steele. And we have to find a way to detect lymphatic dysfunction early. If you walk into an emergency room and you say you have left-sided chest pain and somebody thinks you're having a heart attack, in 1 hour, you're going to have 5 or 6 diagnostic modalities done, blood test, echo, and they're going to know so much about your heart that you know, oh, not exactly, but you're going to have a really good idea of what's going on with your heart. With our lymphatic system, we have nothing like that. What we do is we wait for patients to start growing bigger arms, bigger legs, and then we start measuring it, and then we say, okay, this is how big your arm is. That's the equivalent of letting a car accident happen and then watching, counting the number of dead passengers on the ground. That's a key thing that we need to get better in medicine, in modern medicine. We need to figure out how do we measure lymphatic function at the bedside, in the clinic. And then we take those high-risk patients and we follow them. Or those patients who have lymphedema, we do a lymph node transplant and we can measure how well they're doing, how well their lymphatic train is moving. So I think if you ask me, those are the two areas that I hope in the next 5-10 years, through this massive funding that's coming through ARPA-H, we'll be able to answer.
Right. And that kind of like lead to the last questions to wrap up, which was that, where do we see the future of lymphedema surgery heading to? And it's exactly like first we need to try to do early diagnose, right? And then what else can you do with surgery to prevent it? That's kind of what you mentioned before.
Yeah, I think that's the future. For me, the future is prevention. And for those living with lymphedema, the future is precision lymphatic surgery. Surgery where we go and we have the exact anatomy of the patient, the lymphatic anatomy, I want to be clear, and we know exactly where that patient has a vulnerability, and we go for that vulnerability. And I think our outcomes are going to become much more reliable in that approach.
Great. Just one more question. I was kidding about the wrapping question. How do you see, because this is what happens. So I love the example you put in the ER with a heart attack. So how many cases you see of a patient walking in the ER with a swelling leg? And all the physicians in there have no idea. Well, I'm going to rule a DVT. No, you don't have a DVT. Okay, so you can go home. And then they continue complaining about swelling. And it is like, how do you see we should improve, like training maybe from medicine, medical students, like start to see, because how many patients come here and they've been seeing primary care after primary care, and we don't, vascular surgeons, and nobody really is using the
Yeah,
word lymphedema until they come and see us. And they're like, wait, I've been into 5 different physicians and nobody ever mentioned anything.
yeah. It's a beautiful question, and I'll tell you, first thing I'm going to say, yes, you're right. We need to start from the bottom up, and I'm going to get there in a second. But first thing, just right off the bat, people should know that the Lymphatic Education Research Network, which is a huge patient advocacy group, probably the largest in the world, has developed through an independent body, so this has been vetted, centers of excellence.
Mhm.
They can be centers of excellence, comprehensive, surgery, therapy. So somebody who has swelling out there and they're just not getting an answer, and lymphedema has been floated as a diagnosis, go to the Learn website, look up centers of excellence, and find a center of excellence near you. Okay, these centers, and we know this, you apply, there's a lot that goes into this. Um, they've demonstrated to an independent international board the ability to appropriately diagnose, at the minimum, patients with lymphedema. So that's one thing everyone should know right off the bat, a way to seek care very quickly. I use it myself. One of my colleagues called me recently, and a family member had swelling. They weren't in the area, and they asked, how can I find the closest place in this state? And I went to the Learn website. I looked up the closest center of excellence, and I sent them there. Now, there's a bigger problem, though, right? I mean, there's only, I think, 20 comprehensive centers of excellence. There's different designations, but you're right. It needs to start at the med school level and work its way up. And that's going to take time. That's going to take time. There's no question about it. There's still some hesitancy about, introducing lymphatics into, medical education. But that is something I know many of us are working on in our local environments. And I think, with ARPA-H, for example, spending so much money on this, the NIH, uh, uh, you know, putting money towards lymphatic disease, um, I think there is an attention on this that this train has left the building in terms of this becoming more mainstream as we move forward.
Perfect. And where can people find you, Dr. Singhal? I know where to find you, but how can if they want to come see you? Because if anybody comes and say, who should I see? I say, you need to fly to Boston to see my dear friend, Drew. So I'm gonna put it on the show notes, but if you can just tell the audience.
Julie, that's very kind of you. I was like, how do people find me? Okay, so we're at the Boston Lymphatic Center. It's a joint program between Beth Israel Deaconess Medical Center and Boston Children's Hospital. So we see the entire spectrum and all ages. And you can call us. We have a 1-800 number, 1-833. Oh my God, I don't even know it.
That's okay.
1-833 for your lymph. So 1-833, the number 4, URLYMF.
Okay, gotcha.
So what question you asked me?
Yeah. That's all right. And then I'll put it on the show notes, and I'll put you guys' website and everything, so we'll be there. So I can talk to you forever. This is
I know, Julie,
always
me too.
exciting. Yeah. But thank you so much for your time. And this is, like I said before, I cannot wait to hear more about it. And hopefully I can come up or you can come down, and I love to see you in person.
I'm looking forward to it. Thanks, Darley.
All right. Have a great rest of the evening and good weekend.
You as well.
Thank you. Bye.